Hi, everybody. My name is Harsha Sule. I'm the residency director at Rutgers, New Jersey Medical School, and also the associate director of global health here. And I'll be a moderator today. Thank you for joining us in this in the waning hours of this conference. The exciting part is no one has flights to catch. I'm sure we'll have some people filtering in as well. Given that it's a smaller, more intimate group, our medical student ambassador, Malika Butt, and myself will be monitoring the chat in terms of questions, but feel free also to unmute yourself or raise your hand using the reactions tab in Zoom. Try not to put the questions in the Juno website Q&A section because it's a little harder to monitor there, but if there's any questions, just unmute yourself and we'll be happy to take your questions. Over the next 20 minutes, we're going to have our next speaker, who it gives me great pleasure to introduce, Dr. Landon Mueller. He's currently a sports medicine fellow at Georgetown University MedStar Washington Hospital Center in Washington, D.C. He completed his emergency medicine residency at Virginia Commonwealth University in Richmond, Virginia, and graduated from medical school at UAB University of Alabama at Birmingham. After fellowship, he will be staying on as faculty at MedStar Emergency Physicians in both one of their community places, as well as continuing to do sports medicine. Landon has always had an interest in sports and musculoskeletal pathology, and he hopes to use his knowledge and experience from his fellowship to teach improved orthopedic care to emergency medicine residents. Today, he's going to share his expertise with us by going over, hot off the press, the top 5 practice-changing articles for musculoskeletal care. With that, over to Dr. Mueller.
Thank you for having me, everyone. Let me make sure we get this. Everyone, we're seeing my correct view, not presenter view, correct?
You were correct, and then it just switched to presenter.
Oh. There we go.
Yep, you're good.
All right, very good. Yeah, so thank you for that introduction. We're going to be talking about hot off the press, the top 5 practice-changing articles for musculoskeletal care. I do not have any financial disclosures. I do have some disclaimers, though. This is not a journal club. We're not going to be dissecting these articles for their study design or for their validity. It's basically just going to be going over some of the design and results and the key takeaways from the article. And know that this is only my perspective. This has just been a one-man job going through the literature. It's my takeaways, my interpretation of the literature. So take that with a grain of salt. And this was hot off the press back in 2019 when I initially developed this lecture and submitted it for proposal. So this is still recent literature, but it's all from articles in 2019. And hopefully next year there will be a 2020 update. So how I went about this was not a systematic review, but it was basically I tried to find every journal that I could that might have some relation to emergency medicine, musculoskeletal care. And so I went through a significant number of EM-specific journals. I looked at some ortho and sports medicine journals, and even just some big name journals like JAMA, Lancet. And what I did is went through all of their articles published in 2019 and tried to find ones that I found interesting and were relevant to emergency medicine. And so I came up with the top 5 articles that we're going to be talking about today. And we're going to start off with plaster cast versus functional brace for non-surgical treatment of Achilles tendon ruptures. This was published online in Lancet in 2019. So we know that operative treatment is mostly done here in the US for tendon rupture, but actually throughout the rest of the world, non-operative management is pretty common. And literature published, from both sides of the US and over in Europe, there hasn't really been one, definitive way or over the other. Now, non-operative treatment typically consists of plaster cast in an equinus or plantar position for about 8 weeks. And over the course of those 8 weeks, the patients come back and they get new cast with slightly decreased plantar flexion until by the end, they're in a neutral position and ambulatory. But we know anytime we immobilize something, there are consequences, especially over 8 weeks, you're going to get muscle atrophy. There's theoretical increased risk of DVT. And so there's this idea of, can we do non-operative treatment with just a CAM walking boot, or otherwise called functional bracing? But up until recently, there haven't been too many studies looking at this. So this was a multi-center randomized controlled trial done at 39 hospitals in the United Kingdom. They basically took their population were teenagers and adults with an acute Achilles rupture who chose non-operative management. And they randomized those patients to either receive this serial plaster casting or to have a cam walking boot, which they described as functional bracing, with serial removal of wedges. So at time of initial injury, you have a wedge in that boot, which puts the patient in plantar flexion. And then over time, you get smaller wedges until they're in neutral. Now, a key thing with these two groups is that weight bearing in the cast can't occur until about 6 weeks, whereas the functional group, the cam boot, can be weight bearing immediately. And what they measured was their primary outcome was this Achilles tendon rupture score, which is kind of a patient questionnaire looking at disability, pain, and kind of coming up with an overall score. And then their secondary outcome was looking at complications. Specifically, they wanted to look at tendon re-rupture, DVT. And so the results of this is looking at the ATRS, that functionality disability score. And notably at 8 weeks, so pretty early on, there was actually a statistical difference favoring the cam boot, the functional brace. However, at the 3-month, 6-month, and 9-month mark, there was no statistical difference between the two. Now and then looking at complication rate, there was no statistical difference between the two. So again, no difference in tendon re-rupture or DVT, some of those big complications we worry about. And so kind of taking, what do we want to learn from that is that the functional brace is possibly a little bit better early on at 8 weeks. How much of that is due to the patient's mobile? We don't know within the study, but we also know that long-term there's no difference. And so this is a reasonable option for non-operative treatment to just use this cam walking boot. Now, how does this apply to us in the emergency department? To me, it means that we can just send these patients out with a cam walking boot and make them weight bearing. We don't need to splint them in plantar flexion. We don't need to give them crutches and make them non-weight bearing. We can just put them in the boot and have them follow up with sports medicine or orthopedic surgery where they can decide to further get that operative or non-operative. But the big thing for us is that we can just put them in the cam walking boot. And I think a lot of people might already be doing this, but it gives us further evidence to support that. Moving on to our second article, we have another form of immobilization. Is buddy taping as effective as plaster immobilization for adults with an uncomplicated neck of the fifth metacarpal fracture, otherwise known as a boxer's fracture? And this was published in Annals of Emergency Medicine in 2019. We know boxer's fractures are super common. They make up about 20% of all hand injuries and about 5% of upper extremity fractures. These can often be managed non-operatively as long as they are minimally displaced, closed, and we can tolerate up to 70 degrees of angulation at the boxer's fracture. And we'll talk a little bit more about that in the future. Again, there are divides between what we do in the US and what the rest of the world does. We have multiple options for immobilization. I know we're historically taught to do kind of a plaster cast or in the ER, an ulnar gutter splint. And that's what I learned throughout residency. But again, in the UK and Australia, buddy taping is pretty common, just a minimal form of immobilization. And again, the literature doesn't really lean one way or the other that one is superior. Now, the benefits of ulnar gutter splint is we know for sure that's going to immobilize the joint, but it also makes like physical labor. So if the patient's a laborer, it makes them being able to do their job difficult. And it also makes follow-up difficult, just having this big bulky splint on their hand. And so what this study did out of Australia was look at, can we get away with just buddy taping? So it was a randomized controlled trial. They included patients with metacarpal neck fractures, which are true boxer's fractures. And they excluded basically anything that was a surgical indication. So any open fracture, gross rotational deformity, comminution, intra-articular, those are all indications for surgery, along with significant fracture angulation greater than 70%. And their primary outcome was another kind of questionnaire, self-reported disability score, which is the DASH score. And secondary outcomes were pain and days off from work. Now we're going to take a quick detour onto that 70% angulation, why it actually matters. When I was looking into this study, I kind of went into a deep dive on like, why do we actually care about angulation? And it all has to do with physics and grip strength. And it comes down to the flexor digiti minimi brevis muscle, which originates at the hamate and inserts onto the proximal phalanx of that fifth digit. And it assists in flexing that fifth digit, AKA grip. And anytime you have an increasing fracture angulation, you're essentially shortening the total length of that metacarpal. And since that total length has been shortened, you're going to increase slack in that specific muscle. And because of the length tension relationship in muscles, when you shorten that muscle, you can't generate as much power. And this has been shown in some studies that if you have just 30% of angulation, you can get an 8% reduction in strength at that flexor digiti minimi brevis. And so we normally can tolerate up to 70 degrees, but again, as we can see, that might be a significant reduction in grip strength. So that's why we care about that. I just thought that was an interesting tidbit. So again, going back to the study, what they did was they looked at just buddy taping versus a full-on ulnar gutter cast. And they looked at follow-up at 12 weeks, and they found no difference in their primary outcome of this questionnaire. They also noted that buddy taping missed no days of work, whereas the plaster cast missed a median of 2 days of work. And that kind of goes back to the bulkiness of that cast. There were no difference in pain scores. And for our surgeons who care about fracture angulation and also for that angulation in terms of physical strength with flexion, they found no statistical difference. There was about 3 degrees difference in angulation, which doesn't really matter in practice. And again, it wasn't statistically different. So my takeaway is that for uncomplicated boxer's fractures, the use of buddy tape is possibly as effective as a full-on plaster cast and patient-centered outcomes. And what this means for us in the emergency department is I think this is especially a good option for anyone who's like a day laborer and needs their hands somewhat to function, or for those who just aren't going to be adherent to it. It could even be a good option for those of us with homeless patients. If they're going to be outside, we don't want their cast to get all wet and gross and non-functional anyways. So buddy taping may be a more reliable option that they'll actually use. Now, again, this isn't widely adopted in the US, but I think for these, those specific situations where it's kind of a best case scenario, I think that's something to consider. So moving on to our third article, we have a comparison of oral ibuprofen at 3 different treatment regimens for treating acute pain. This was also published in the Annals of Emergency Medicine. Now, we actually have some interesting literature out of the dental and oral surgery world, which they found kind of in their world that there is an analgesic ceiling dose for ibuprofen of 400 milligrams a dose, or 400 milligrams 3 times a day, up to 1200. There's been another study when we look at GI complications that when we increase the ibuprofen dose from 400 times a dose, 400 3 times a day, up to 600 milligrams 3 times a day, you actually double the odds of GI complications. And one of the reasons why we might want to give a higher dose of ibuprofen, like 600 or 800, is that it does have a linear kinetic pattern, which means that higher doses have a longer duration of action. But we've never really studied this in the emergency department. So what this was a single site at Maimonides, where it was a randomized double-blind trial. They looked at pretty much adults coming to the emergency department with acute pain that needed treatment with ibuprofen as determined by the treating attending physician. So it was pretty broad inclusion criteria. They did exclude GI bleeds and renal insufficiency. And they had a pretty ingenious way to blind the provider and the patient. They had the pharmacist crush up the ibuprofen and mix it with a sweetener into a liquid medium so that all the patients drank the same amount of liquid that no one could tell had the amount of ibuprofen. And their outcome was just pain scores measured at baseline and then 60 minutes after getting the medication. Now, in terms of their patient population, they were fairly the same between the groups. And notably, this was mostly treating musculoskeletal pain, about 3/4 in all the patients. The rest was made up of cutaneous pain, dental pain, some headaches. And the big kind of result was that their pain scores were equivalent between the 3 groups. All groups kind of had a pain score of around 6 before treatment, and they all dropped down to around 4. And there was no statistical difference in those groups. And so we can conclude for the short-term pain relief, which again, they measured at 60 minutes, ibuprofen at 400, 600, and 800 milligrams resulted in similar changes in pain, which was about a 30% reduction. And it kind of supports this idea that 400 milligrams may be the analgesic ceiling dose. Now, the biggest limitation of the study is that 60-minute mark. And again, I mentioned the linear kinetic order, we may get some extended pain relief with the 600 or 800 milligrams. But again, we may also have worsening adverse effects from those doses. And this study was just single site. There weren't nearly enough patients to really tease out any changes in adverse effects. So something to consider, but I think it also lends support that 400 is that ceiling dose. Going on to our fourth study, we have a new diagnostic test, or at least new to the emergency department literature. So this is implementing the lever sign in the emergency department. Does it assist in acute anterior cruciate ligament rupture diagnosis? This was published in the Journal of Emergency Medicine. Now we care about ACLs in the emergency department because if we don't catch an ACL and the patient doesn't get it treated, there has been shown to have a significant increase in arthritis from those that don't get it. Now it's often hard for us to diagnose ACL tears in the emergency department because it's been 1 to 2 hours after the injury and the patient has significant onset of swelling and pain. Whenever we see an athlete on the sideline, they're coming right off of the injury, they haven't had that hematoma kick in, they haven't had that pain kick in, so we can actually get a decent exam. But by the time these patients show up to the emergency department, they're in a lot of pain and they don't necessarily want you performing a Lockman on them where you're yanking on their tibia and femur. And regardless of the pain, we actually know that the study characteristics of those tests are far from perfect. Sensitivities range between 18 to 92% for the Lockman test. We know that those who do it all the time, like orthopedic surgeons and sports medicine docs, have a slightly higher sensitivity compared to ER docs. But again, they're still far from perfect, even those of us who do it frequently. And this is reflected in one study that showed that only 26% of ACL tears are correctly identified in the emergency department. So a new test to be able to identify this would be helpful. And that's where we get the lever sign. You may also see it in the literature as Lelli's test, because it was an Italian surgeon called Lelli who first described it. And it's pretty simple. With the patient lying supine, you put your hand over their proximal calf and you create a lever through their knee joint. You then push down on their distal quad and see if their foot rises off the bed. So again, what you're doing is you're creating this lever. And if the ACL is intact, if that ACL is connected to both the femur and the tibia, theoretically, when you push down on that femur, that's connected to the tibia and it will raise up that tibia through that fulcrum. Whereas if your ACL is not intact, when you push down through that quad, their foot will not rise up the bed. So it's a yes or no test. Either their foot rises off the bed or it doesn't. And what this study did was a single site. They looked at probable ACL tears that came into the emergency department in adults. And what they did was for the first half of the study, it was like 4.5 months or so, in the emergency department, all the providers performed the lever sign. And they said, yes, no, ACL tear. Those patients then followed up in a sports medicine clinic and they got followed up by the traditional test, Lockman and anterior jaw to compare. And all those patients also got MRI. They then flipped it then over the next several months. And in the emergency department, they did traditional chest test. And in clinic, they did the follow-up lever sign. And they compared all those patients to MRI and studied the test characteristics. And the biggest thing is it was a pretty small study. There were only 8 patients that actually had a confirmed ACL rupture. But what they report is pretty impressive statistics. They report a sensitivity of 100% for the lever test compared to only 40% for the Lockman. Now, again, this is a small study. Only 8 patients actually had a positive ACL tear, but they report 100% sensitivity for catching it. My takeaway is, regardless of those statistics, it's a pretty easy test to perform and it's pretty easy to interpret. And therefore, I think it makes it a good screening exam. And it might be more useful in the emergency department because it's less painful than the Lockman maneuver. Again, there are some downsides to the small study, but I think it's pretty easy to implement in practice. And then moving on to our last one, which is arguably my favorite study, patient comprehension of common orthopedic terminology. Now, this was published in a small random journal, Health Literacy Research and Practice, but it highlights some pretty interesting findings over healthcare literacy. And we know from lots of other literature that doctors frequently overestimate patient healthcare literacy. And this is especially true in patients with lower socioeconomic backgrounds. And So what this study did was look at this specifically for orthopedic terminology. This was just a cross-sectional, essentially questionnaire given at a trauma center in Australia. And these were all just patients with isolated orthopedic injuries that were in the ER and on their orthopedic inpatient unit. And they found some very interesting findings. I think this is the biggest one. In this questionnaire, they asked if the fracture is the same as a broken bone, worse, or not as bad. And only 35% of patients knew that a fracture was the same thing as a broken bone. So when you tell a patient, when you tell your patients that they have a fracture of whatever bone, 2/3 of them don't understand exactly what that means. So we need to be super explicit with what we're saying. Some of the other interesting things, if we tell a patient to avoid weight bearing, they found that only 70% of the time they understood that that means they need to use crutches all the time. And then also, 40% of patients only partially understood their injury, its treatment, and any restrictions. So the other thing about this study was, again, done in Australia, and their patient population was pretty smart. 50% of them had a university degree. And they did some regression analysis and found that those that had a university degree had an odds ratio of 2 compared to non-high school degree in terms of understanding. And so I know that those of us in the US, we do not practice in emergency departments where half of our patient population has a university degree or higher. And so what we need to take away is that orthopedic medical terms are often misunderstood, especially in those that have poor health literacy from poor socioeconomic backgrounds. I think we need to explicitly say you have broken whatever bone instead of fracture. And so going back to my actual takeaways, just highlighting everything. For Achilles tendon ruptures, you can send those patients out in a walking boot with a wedge to follow up with ortho or sports medicine. Consider buddy taping for your patients who aren't going to tolerate a full ulnar gut or splint. Consider using only 400 milligrams of ibuprofen. It's possibly the analgesic ceiling dose. Try implementing the lever sign when examining the knee. It's pretty easy to do. And focus on using simple orthopedic terminology. Specifically use the term broken bone instead of fracture.
Great. Thank you, Dr. Mueller. We are a little bit over time, and I confess that I was too involved in taking notes of what you were telling us to pay attention to the clock enough, but I think being on a Zoom, we have a little bit of flexibility there. So if anyone has any questions, feel free to just unmute yourself. We're a small group and go ahead and ask. The quick question I have for you real quickly is regarding the buddy taping. I know I've come across that in the pediatric ortho literature as well, it's much more common to consider using buddy taping as opposed to in the adult population. And obviously their bones are much more, I guess, still forming and everything, so more flexible. But I wonder if this is just a corollary to that in the sense that there's a lot of these injuries that we're overdoing things perhaps.
Yeah, I mean, I think that's kind of echoed in both of those immobilization studies, that we probably don't need to fully immobilize a lot of the things that we actually do. Certainly when fractures, dislocations are unstable, it makes sense to fully immobilize them. But for a lot of these fractures, in a specific study where it's pretty uncomplicated, not a whole lot of angulation, no displacement, the human body's pretty resilient. And so we don't need to do a ton of immobilization. And yeah, maybe adults aren't quite as unmalleable as they are compared to peds.
Right. I noticed that one of the co-authors on the ibuprofen study was, I think, our medical student ambassador on this session, Malika Butt, as well.
Yeah, it was so cool to see that. Thank you so much for including our article into your presentation. It was really nice to see it represented.
Great. So we are at time, so we need to unfortunately end the session. So that way our SAEM staff can also move on to the next session. Thank you very much, Dr. Mueller, and to the audience as well for being part of this. Appreciate it. Great job.
Thank you, everyone.